I'll give you a little of his CV. He's a professor of metabolic research at Weill Cornell Medical College. He's an attending physician at New York Presbyterian and adjunct clinical associate professor of medicine at Columbia University College of Physicians and Surgeons. In other words, Lou Aronne knows what he's talking about. Hey, Dr. Aronne, how are you?
Oh, hi, Katie. How are you?
Nice to see you. I know this is your inaugural Instagram Live, so welcome to the platform.
It's a pleasure. It's great.
I'm really happy to be talking to you because I think there have been a lot of stories about these weight loss drugs, and I think a lot of people are really confused about it. And I think, honestly, Dr. Aronne, concerned about it because they seem to be all the rage, and I think people are worried that the people who should be taking them aren't taking them, and the people who shouldn't be taking them are. So let's start from the very beginning, as Maria von Trapp would say, Dr. Aronne. Ozempic. First of all, I can't get their theme song out of my head because it's, I think, a 70s song about magic that they've co-opted. But can you explain what Ozempic is?
Ozempic is a medicine that is derived from other medicines that have been on the market for over 20 years. And Ozempic is the most effective version of this type of medicine called a GLP-1 agonist. What does that mean? It mimics the effect of an intestinal hormone that's released when you eat food. So when you think about what is Ozempic, it's mimicking hormones that are a hormone that's released into your intestine when you eat food. And that hormone is absorbed, it goes to your brain, and it tells your brain that you've eaten, so you feel full. It also goes to your pancreas, and it stimulates the release of insulin, a hormone that lowers your blood sugar. So it's very much a physical or physiological signal that mimics eating food.
So it basically makes you feel full. And I've read, Lou, Dr. Aronne, that some people say that it makes food taste bad, or it takes the appeal out of food. Can you explain that?
So I've seen that from time to time. You know, we've been using Ozempic, by the way, for 5 years. It's been around for a number of years. And it's only last year that a diabetes version, that it went from being a diabetes version, the same medicine was approved as a weight loss version called Wegovy, and that's when this really exploded. Interest in it exploded. But that can happen sometimes, and we don't really understand why it happens in some people and not others. But I have seen people say they have a taste aversion to one food or another.
But basically, it makes you feel full even when you haven't eaten.
So the average person will tell us this: I went to my favorite restaurant, I ordered my favorite meal, and I could only eat half of it. And I was looking at it saying, like, how could I have ever eaten the whole thing? Now I could just eat half, that's it. And so if you say, okay, that's it, and you take the rest of it home and eat it the next day, you're going to lose weight. But if you keep trying to stuff it in because you paid for it, you may not do as well.
So there's, what is Manjaro? You said Wegovy is the weight loss version of Ozempic. Ozempic is actually for diabetics. Wegovy is for weight loss. So I guess it's a subset of that Ozempic. And what is Manjaro?
Manjaro is a completely different medication. And Manjaro stimulates or mimics the effect of two different hormones. One, GLP, the other called GIP. So it has a dual mechanism of action. And what we've learned over the years, and something that my own research showed a number of years ago, is that when you combine medications that affect weight regulation and appetite, you can get past the plateau phenomenon. So you can get additional weight loss by combining two medicines that work in totally different ways. And as a result, we get more weight loss with Manjaro. We published a paper on this in July showing weight loss as great as 22.5% with the highest dose. Really, it's very similar to bariatric surgical weight loss.
Interesting. And what are the side effects from these drugs, Dr. Aronne? And I mean, do all of them have different side effects, Ozempic and Wegovy versus Manjaro?
The side effects are actually very similar. And Katie, call me Lou. It's okay.
Okay, I'll call you Lou.
So, yeah, we've known each other for a long enough time. So, nausea, vomiting, diarrhea, constipation. So just think about eating a really big meal. You could feel queasy, and you can have gastrointestinal upset. We find that in using these medicines properly, and that's one of my concerns, is that there are people out there who are not using these properly, but in using them properly, we find that the vast majority of people tolerate them well. And what does properly mean is to go up very gradually in the dose, month by month. It takes 5 months to go from the lowest dose to the highest dose. I've heard of stories of people starting with doses that are in the middle or higher, and that is guaranteed to give someone side effects.
So I think the big debate right now is who should be taking these drugs. By the way, if you all have any questions for Lou Aronne, please ask them in the questions section. I took the comments out because it was covering your face, Lou. But, who are these drugs for, basically?
Right. So Ozempic and Manjaro are for people with type 2 diabetes. They're approved for people with type 2 diabetes. And Wegovy is for people with obesity. And when we say obesity, it's measured based on the body mass index. So someone with a body mass index of 27 to 30, which is about 30 to 40 pounds overweight, would qualify if they have problems like diabetes, high blood pressure, sleep disorders, other medical problems that are associated with their weight. And anyone with a body mass index of 30 and above would qualify for Wegovy. And the thing that is being lost in the discussion is that these medications are a huge advance in the treatment of serious obesity. So this is, these weren't developed for cosmetic uses, but they're being used cosmetically because they're so amazing in their effect. But the thing I'd like your viewers to know is that these medicines are transforming the lives of people who have been untreatable in the past, people who were really suffering health problems because of their weight. The average patient we see here at our center at Weill Cornell, the average man weighs 270 pounds. The average woman weighs 230 pounds. You can imagine the health risk. They have a body mass index of 37. They're on 7 or 8 medications, and more than half have sleep apnea, a sleep disorder that's associated with weight. And, with medicines like this, we can get people to lose 40, 50 pounds or even more. Today I just saw someone who lost 70 pounds, someone else who lost 60 pounds. And once you lose 15% of your body weight, if you can lose 15% of your body weight, almost all of your health complications from obesity can improve. They won't go away, but most all of them will improve. So we finally have tools that can get us that without the ultimate tool, which is surgery.
Well, I want to ask you, for these particular patients you're talking about who have a 37% BMI, right? Have they failed, or is there something about their bodies or their physiology that makes it very, very difficult for them to lose weight without medication?
Sure. No one comes to see us unless they've tried many dietary interventions. And I want to emphasize that what these do is help people to comply with a healthy diet. This is not instead of a diet. This is along with a diet. And many people can lose weight with diet and physical activity alone. You know, I don't want you to think that I think that it's not possible to do. But what do you do if that doesn't work? You know, this is what I always ask people at insurance companies. Put people in this behavioral program, but let's say it doesn't work and they have all of these complications. Do we just sit there and wait until someone needs surgery? So the answer is that the medicines help people to feel like they've eaten already, and that helps their dietary compliance. So ask yourself, like, why is it that people can't lose weight? Why don't people just lose weight? And the answer is that in the process of gaining weight, something physical changes in your brain that makes it hard to lose. What is that? There are nerves that receive hormonal signals from your fat cells, stomach, and intestine. Some of them are these hormonal signals like GLP. Your brain becomes desensitized to those hormonal signals because the nerves get damaged in the process of weight gain. And I can give you an hour lecture on how it happens, but the point is it does happen. So something physical is going on in the background. You can't see it or feel it, but anyone who's gained weight and has tried to lose knows just what I'm talking about. You try to eat less and you just don't feel right. You may feel hungry. You may wake up in the middle of the night thinking about food and you think you're losing your mind, but you're not. It's your body trying to tell you that you're losing weight, you're starving to death, you know, go out and find food.
Well, so you're talking about individuals who might be described as, if this is correct, Lou, morbidly obese, right?
Well, morbid obesity or severe obesity starts at a body mass index of about 35. So the patients who we see, you know, severe obesity begins 35 and then really begins at a BMI of 40. But anyone with obesity can suffer the complications like diabetes or other.
Yeah. So you're talking about people, I understand, who are like 30 or 40 pounds overweight.
Yes.
Okay. I guess what everyone is talking about, I'm going to get to the questions in a minute, is that people who are not that overweight are taking these drugs to lose maybe 10, 15, 20 pounds. And I want to ask you about the long-term side effects, but are you concerned that people who don't really need these drugs, in other words, they don't have some of these other comorbidities that accompany being, you know, too heavy, that they are taking these drugs? And what is your opinion on that?
Well, I can't really comment on that. These medicines haven't been tested in people who are close to their normal weight. So we really don't have a lot of information. My belief is that they'll turn out to be safe, but they haven't been studied in that exact group of people. So I can't speak from any experience or research data saying that it is in fact safe in people like that. You know, so in people who are heavier, we know that they're at health risk as a result of the excess body weight. And so reducing the body weight gives health benefit. So that balances out any risk from the medication. The same way that we do bariatric surgery in people with severe obesity, and it's been shown that they're more likely to live than, you know, die from surgery or other complications. Mm-hmm. We don't have those studies yet, but we're going to have them soon. And we believe that the power of the weight loss will overcome it. But again, for people who are using this cosmetically, who are very close to their ideal weight, I can't say that I know it's safe or unsafe.
Well, what about, what happens when people who use it stop using it? I mean, I've heard that
Sure.
You gain the weight back. One person reported that their binge eating disorder got worse. You know, basically, and the other criticism is that doctors are just handing this out like candy. Chelsea Handler, I don't know if you know who Chelsea Handler is, but she said that she didn't even know she was on it and that her doctor hands it out to anybody.
Right.
So, I mean, are you concerned that it's being abused? And then we'll talk about the long-term side effects.
Right. I wouldn't call it abused. Maybe it's being misused. And I don't agree with doing that, obviously. I think
I
that,
mean, are you concerned about it?
well, I focus on what we do and the fact that we finally have tools that are available to people who had none. Like I see patients all day long with our, the 9 other doctors we have, and we use the medicine appropriately. And, we see patients who benefit enormously. The fact that there are people who are not using it properly, I'm not sure what we can do about that. Should they do it? No. Should this be controlled in some other way? I'm not sure.
What about when you stop using it?
Sure.
Does the weight return? Is this something you have to be on for life? And what are the long-term side effects of being on this drug?
Sure. So just like diabetes, high blood pressure, high cholesterol, if you were taking medicines for those and you stop them, you would expect your blood sugar to go up, your blood pressure to go up, your cholesterol to go up. Obesity is the same type of chronic disease and the leading cause of those other diseases. So we fully expect that if you stop the medication, your weight's going to come back. Now, it's probably not going to come back the week after you stop it, the way your blood sugar would go up or blood pressure. But over time, you will gradually regain weight because your appetite will come back. It's almost like you stopped eating that food that the medication mimics. And so your body's going to be looking for more food. So this is something that, as an obesity medicine specialist, we have come to expect. And, our plan for patients is chronic use of these medications. It may be that some people, we've seen this before, where people don't need to take the medication every week forever. They may take it less frequently, several times a month, but chronic use is what we expect.
Really interesting, because I've seen that the longest study took place over less than 2 years. And some physicians say that really isn't long enough to determine the long-term effects of being on a drug like this in perpetuity.
Right. So there are studies, so medicines like this in this category, maybe not these exact medicines, but medicines like this have been around for 20 years, medicines in this category. And so when a medicine has been around for a longer period of time, you get more experience. Let's look at Ozempic, for example. Ozempic has been around for over 5 years and used by millions of people. We would hope that if there were a signal of some type of a risk, it would show up. And it hasn't. Again, this is a medicine that is widely used. It's become one of the most prescribed medicine for people with diabetes, and we haven't seen anything. But that doesn't mean that it should just be handed out to anybody who walks in the door. So I'm not disagreeing with you, but I'm saying that the safety profile seems to be quite good.
Someone asks if you're concerned about semaglutide lowering blood glucose levels in non-diabetics. I don't know exactly what that means, but this person must.
Semaglutide is Ozempic or Wegovy, and it can lower blood glucose in people. The studies that have been done in people without diabetes have shown that it is rare, can happen, but it is very uncommon. And again, that shows that this is a medicine that is meant for use in appropriate populations of people, not just anybody walking in off the street.
What are your thoughts about using hormone therapy and weight loss treatment, i.e. bariatric medicine?
You mean the other medical treatments that we have?
Yeah,
so
I guess. This is a question from a viewer.
Right. I think they may be referring to these medications because they are GLP-1 and GIP and others are hormones. So I agree with it. I mean, this is, I've been doing this for over 30 years, trying to figure out why it's so hard for people to lose weight. And we've done more than 100 studies on dozens and dozens of medicines looking for things that would work to alleviate the problems that people have. And, we finally are there and have effective and safe medications. And so I'm ecstatic. So do I think it's a good idea? I think it's a great idea. I mean, we've published 5-year data with the older medication showing that we can get 10% weight loss with older medicines. Now we have Wegovy, produced 17% weight loss. Manjaro, which is not approved yet for the treatment of obesity, that produced 22% weight loss. So we're in a whole new era. I mean, think about it. You have diabetes, high blood pressure, and a high cholesterol, and a sleep problem. Would you rather lose weight with a medication, or would you rather treat those, but they don't make you lose weight?
With multiple medications,
with multiple medicines, devices, and other forms of treatment. That's correct.
Someone else writes, I lost 50 pounds on Trulicity in 8 months. Will I be taking it forever? I'm 64 years old.
Right. So Trulicity is an earlier version of Manjaro and all these other medicines. It's similar to Ozempic. And that's great that the viewer lost that weight. But the short answer is, yeah, if not that medicine, if not Trulicity, maybe one of these others. But it's the same way. If you were on insulin, would you expect to be able to take insulin for a period of several months and then go off it? And the answer is, nobody would expect that.
Someone asked if you get compensated by any of these companies to use their drugs on your patients.
So the short answer is no, I don't get compensated by the companies, but I do research. I consult for the companies. Again, I've been doing this for a very long time and have done dozens and dozens of studies, looking for solutions for people who have suffered mightily over the years.
Let me ask you about this new obesity, these guidelines by the American Academy of Pediatrics. They released new guidelines for treating obesity in children. They're calling for kids who are 2, who have weight, I guess, or overweight, to have behavioral changes, and as young as 13 to take drugs and, seek surgery. And these new guidelines, as you probably know, have stirred up a lot of controversy. Can you talk about the recommendations? And, I think it's really hard. I think as a society, we have whiplash. We're talking about body inclusivity. We're talking about the fact that you can be healthy and overweight. And yet then we're hearing about all these drugs. And I think it's very confusing for people. But first, Lou, will you talk about these American Academy of Pediatrics guidelines and if you think they go too far?
Sure. I mean, frankly, again, as an obesity medicine specialist and someone who's been involved in this field at a high level for a long time, I don't think they go too far. I think they're appropriate. And what I would say to people is you just have to be here and see the patients with us and see what we have to deal with. Children developing adult type diabetes, a child developing adult diabetes that their grandparent may have developed when they were 60 and their parent developed when they were 45. And then here's a child who's gained a tremendous amount of weight at a very early age, and they have adult type diabetes when they're 10 years old or younger. I mean, the youngest I've heard of it, Columbia Presbyterian, our sister institution, was a 5-year-old with adult type diabetes. So there are many, many severe cases that are now developing. And here's an important point. When it comes to the medical profession and obesity medicine, we're not telling people to go to some ideal weight. We're not looking for an aesthetic goal. We're looking for a health goal. With a 5% weight loss, you can reduce your risk of developing diabetes by 50%. with a 10% weight loss, you can reduce the risk of diabetes by 80%. So you don't have to get a lot of weight loss to get health benefits.
Mm-hmm.
And the problem in pediatrics is that the physicians, the pediatricians will keep saying it's okay. We'll just keep watching. We'll keep watching. We'll keep watching. And meanwhile, these complications are developing. And what is being observed is the complications that we see in people with diabetes that normally happen when they're in their 40s, 50s, 60s, and older, happening in teenagers. So I think that they're responding to this type of urgency that, it takes at least 10 years, by the way, before guidelines get implemented. So you come out with a new set of guidelines and it takes at least 10 years and as much as 17 years before they really make their way into the standard of care. So I think they're trying to draw a line and say, we need to be moving forward with this type of treatment. I mean, that's my honest opinion.
Okay, a couple of quick questions. Is the BMI, many people are asking, is that still a good indicator of health? Or I know it's been around for quite a while.
Yes, it's been around for a long time. It costs nothing to do. There are probably better indicators that are now being developed that look at body composition, where your fat is located. And, there are now techniques with your cell phone, you can scan somebody and see where their fat is located. So for now, it's the best that we have, and it's been very widely studied, but it's definitely not perfect. There are people who have more muscle mass at a given BMI, and there are people who have less muscle mass. The people with more fat and less muscle are at much higher risk than people with more muscle and less fat. And that's not taken into account.
Having said that, can you be 20, 25, even 30 pounds overweight and still be healthy?
You can. You absolutely can be 20, 25 pounds overweight. But as your weight gets higher and higher, it's less and less likely to be healthy.
Let me read you just a quick excerpt from an op-ed by someone named Virginia Soul Smith, who has a book coming out about parenting in the age of diet culture. She writes about the new Academy of Pediatrics guidelines. The guidelines acknowledge that experiences of weight stigma, victimization, teasing, and bullying are major challenges faced by kids in larger bodies that contribute to disordered eating and worse mental health outcomes. Some healthcare providers, they note, are biased against fat patients in ways that compromise the quality of care and contribute to more severe illness and even death. And yet, by framing the new guidelines around the best ways to pursue and achieve weight loss for kids, the Academy reinforces that bias. It relies heavily on BMI as an indicator of health status, even though mounting evidence reveals its limits. Our weight-based medical model trains doctors to see normalizing a child's BMI as the priority rather than to view that number as one data point to be curious about. I'm just interested in your reaction to that.
Sure. Well, first of all, I don't think any physician who's treating a child is looking at just their BMI, but also looking at their cholesterol, their blood sugar, and the other complications. The problem has been that typically you'll see children in the 99.9th percentile of weight, like so way off the charts in weight, and nobody is doing anything about it. That's the problem. So no one is saying that a child like that needs to get to their ideal weight. They need to get closer to normal. And, again, you have to just see it and practice it. I'm not a pediatrician, but I've seen patients where, a child is so far off the charts in their weight, and they're developing complications, and everyone's just standing around saying, okay, well, wait, try to do this, try to do that. I think that what this is doing is giving specialists in particular the ability to start stepping up and developing techniques and treatments like we do in adult medicine to try to help children who are suffering with it. So remember that once obesity starts, okay, it keeps on going. Something physical happens in your brain that makes it hard to go back. And for some people they can, and for others they can't. And so intervening early is probably a really good thing, just like it is with blood pressure and cholesterol. If you intervene early, you don't get to the point with blood pressure where you have heart failure and a stroke. But if you wait too long, that kind of stuff is going to happen. We think that obesity needs to be treated earlier as well.
I know you have to go to a party, a dinner for your team, but a lot of people are asking about insurance coverage because these drugs are quite expensive.
That's right. And it's going to take time, but right now we get insurance coverage on from about 40% of the payers for our patients. And I think that given the efficacy of these medications, we're going to see greater coverage over the coming months and years. And there are several important trials that are now going on that will do a lot to help with coverage. They're called cardiovascular outcome trials. And they look at whether people are more likely to have a heart attack, stroke, or die if they're taking the medicine or if they're taking a placebo. And the results of studies like that help to inform us about whether what we're doing is going to prolong life and reduce healthcare costs. And the preliminary information we have from previous studies suggests that losing weight should make you live longer. It should, and a healthier life. Once the large studies with these medications are completed in the next 1 to 4 or 5 years, I think we're going to see more coverage. So ultimately, my goal has been to move the treatment of obesity into the mainstream of healthcare, which is where it belongs, so that you don't have to wait until you have all of the complications. That makes much more sense to me.
Right, but just to summarize some of the things we've talked about, these drugs are really for people who are how many pounds overweight and not for people who are how many pounds overweight.
These are called anti-obesity medications. They're for the treatment of obesity. And obesity begins at a body mass index of 30. And if you look at that, that's about 50 pounds overweight.
50 pounds overweight.
That's right. Somewhere between 40 and 60 pounds, depending upon how tall you are, would be the most common amount. So it's not for somebody who's 10 pounds overweight and wants to look good in a bathing suit. That's not what this is for.
And you are, I know you said you don't have that much information, but I imagine you would be concerned about people who are in that category and are using these drugs.
Well, do I want them to be using them? No. I think they should let us treat people, and especially if it's going to impair our ability to treat the people who really need these medications. And there are many, many people. I mean, if you look at some of the most recent statistics, it suggests, so this is the most recent prediction, is that by 2030, 25% of the US population will have a BMI of 35 and above, severe obesity. That's unbelievable when you think about it. So, thinking about using medicine, I know some people have difficulty wrapping their heads around it, but if we don't do something, it's only going to get worse. It's only going to get worse. And, the kind of treatment model that we are embracing is one like high blood pressure and the other chronic diseases that we know that obesity is the leading cause of.
Are you worried that because this has gotten so trendy that you won't be able to treat the people who truly need it?
it's been a challenge, but I hope that we will have, an ample supply of these medicines sometime in the near future. I mean, it's already better. So I'm not worried that we're not going to have the medication, but I think that, I don't think anyone really anticipated the demand for these medicines because it has never happened before. Other medicines have come out that weren't as effective, and nobody was really interested in them. This is the first time that there's been this enormous interest.
But should there be medical guidelines, Lou, so doctors will only give this drug or these drugs to patients who truly need them? I mean, to me, you said misusing. I think it's abusing these drugs for people. I mean, we don't know everything about these drugs. And as you said, they haven't been tested on people who are considered mildly overweight. So shouldn't doctors be much more careful about who they're prescribing these drugs to?
So the short answer is there are guidelines. And there have been guidelines for 20 years. I've written some of the guidelines. And so, what I've told you, body mass index of 30 and above and a body mass index of 20 to 30, if you have complications, those are the guidelines. Those are the guidelines. It's pretty clear that physicians feel they will be safe and they're ignoring the guidelines.
And that's something that you're concerned about, clearly.
Mm-hmm.
Well, Lou Aronne, it's certainly being talked about everywhere, these drugs, and it's interesting that you feel that they're a great breakthrough for people who are, I guess, what you would describe as clinically obese, which you said anywhere from 40 to 60 pounds overweight, who have a whole host of medical problems attendant to that extra weight. And I think it's going to be interesting to see what happens as people who are not in that category demand it and take some of this medication away, the supply away from people who really need it. Lou, thank you. I hope you have a nice time with your team out. I know your guys are going out to dinner, but really appreciate your explaining this to us today.
Thanks, Katie. I appreciate your having me on.
Okay. Bye, everybody. Thanks for your questions.